Okay, good evening everyone. My name's Lucy Dobson and welcome to our Transgender in General Practice webinar this evening. I am filling in for Bianca Forrester, who unfortunately can't be here today to facilitate our evening. She's off receiving an award for International Women's Day, which we're all very proud of her. And I'd also just like to introduce Jade, who's behind the scenes today from the PHN, who'll be assisting us tonight with any sort of housekeeping or logistical questions as well. So I'd like to begin by acknowledging the traditional owners and the custodians of the land and waterways from which we're all zooming in from tonight. We recognise the diversity, resilience and ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past, present, and those that are those connecting in today to our webinar. We commit to working together in the spirit of mutual understanding, respect and reconciliation. We support our self-determination and First Nations peoples organisations, and we work together on closing the gap. Tonight, I'd also like to acknowledge the trans and gender diverse community and those with lived experience, that they have an incredibly important role in advocacy and taking part in roles in our community to contribute and support and evolve the opportunities that others have for the transgender community. Tonight, we'll be joined by Merrin, who has the lived experience of a parent of a transgender child, and we thank her for joining us tonight, and we look forward to having a lot more people with lived experience in our coming educational sessions, hopefully later in the year as well. Having a bit of trouble moving my slide on. There we go. So just a little bit of housekeeping. So on the slide in front of you, you've got some upcoming events that you can see. So these are all events that will be recorded, and the major events that the PHN provide are freely available on the PHN Learn YouTube channel. And there's a link to the channel in the chat that Jade will put up for us. And I'd also like to make a special mention of the PHN Refresher Weekend, which is coming up on Saturday, the 25th of May and the 28th of May. This is a hybrid conference where you can participate at sites in Geelong, Warrnambool, Horsham, and then online as well. And the theme will be toddler to teen. So all the details are there on the screen. I'd also just like to make you aware of the health pathways that are available for the transgender care in general practice. So there's topics we'll talk about tonight and resources are available through these links. And if you pop onto the resources page through the health pathways, you'll be able to access what we refer to tonight, and we'll also send out a document after the event with anything that we may have brought up that you might like to pursue further. So I just want to make you aware that participants tonight will remain on mute. If you have questions, I highly encourage you to pop them into the chat. It can be anything at all. Don't hesitate about putting up barriers to what you might be experiencing throughout the care that you provide any of your transgender patients. Any questions about social or medical affirmation, we will try and get through them all, and hopefully we'll answer quite a bit for you. And we'll ask them throughout the course of the evening as well. I ask that you have your name displayed correctly on your attendance tonight. And if not, there's a rename function that you can use in the purpose of issuing certificates for attendance for CPD. So please just make sure that's correct. And if you have any issues, just ask Jade in the chat. You'll see on the screen the evaluation survey. So we ask you to participate in a few questions after the webinar is done. We'll put this slide up again at the end of the webinar, and the QR code and the link will also be in the chat. So our agenda for tonight is that I'll introduce our panel of speakers. We'll work through the learning objectives, and we're also going to discuss 3 cases, and the last case is a split case, but the same patient. So I do hope that there's lots of discussion tonight. Tonight, we're aiming to provide a space that will help build services in the region, highlight where their gaps may lie, and also try and collaborate with everyone about how we can work together and support our trans and gender diverse community. We want to bring practitioners together and encourage you again to put any questions in the chat so we can see what's happening out there. So tonight I'll just introduce our speakers. So we have Nick Brayshaw, who's a general practitioner who works at Kardinia Health and has been working in trans and gender diverse care for some period of time. I will also be presenting on behalf of general practitioners, and our other panelists tonight, we have LGBTQI+ family and child practitioner, Merrin from Queerspace, and Paediatrician Dr. Jo Centra from Barwon Health. So thank you for joining us tonight. So the learning objectives are outlined on the screen at the moment, so I'll run through those with you. We hope to outline the primary care models in general practice for transgender patients of all ages, so prepubertal, peripubertal and adult patients. We plan to outline referral pathways and highlight the possible wait times for trans patients with these current specialist access. We hope to describe social affirmation for transgender people in detail, and hopefully you feel confident with that by the end of the presentation. And lastly, but very importantly, to describe the potential harms of not supporting the transgender people in achieving gender affirming or providing inclusive care. So I'm just going to speak to that a little bit further. And what I'm presenting to you now is some information from a survey that was conducted in 2017, or was published in 2017, from the Trans Pathways. And this highlights from a survey of about 860 trans young people, the experience that people had in receiving medical care. So these trans and gender diverse young people, about 60% experienced feeling isolated from medical and mental health services. Approximately 42% reached out to a service provider who did not understand or respect, or potentially had experienced transphobia in those consultations. And this is really important when we look to the other side of the screen here, and it just shows that the prevalence of self-harm in this age group is up to 80%. Attempt at suicide is 48%, which is actually 20 times higher than the general population at this age group. Trans and gender diverse young people are more likely to be diagnosed with depression and anxiety. And again, this is 10 times higher than the age groups, than the general population in these age groups. And also these young people experience peer rejection. 90% experience peer rejection at school, or about 74% bullying. And what I haven't put up there is that they experienced issues with, about 80% experienced issues with either the school environment they were in, the TAFE environment, or the university. So I think that highlights why it's so important we provide such inclusive care and such important affirmation for these young people and adults. So all the content we present this evening is based on our knowledge of the standards of care, which are Australian-based and world-based as well. So we have the Australian Standards for Care and Treatment Guidelines, which have been produced for trans and gender diverse children and adolescents from the Royal Children's Hospital. We have the AusPath Guidelines, which is the Australian practitioner group in Australia for trans health, and their standards around informed consent for gender affirming hormone therapy. And more broadly speaking, the World Professional Association for Transgender Health provide us standards of care. And most recently, this version 8, was published in about October, November last year, which has been quite progressive, and now all of our standards will have to slowly improve as well. So we'll get into the case studies. And so I'll introduce you to Holly. So Stacey presents with Holly, who's now 8 years old. You've been the family doctor for Stacey and her 3 children since they were born. You've known Holly previously as Ollie, and in this visit, the family ask you to use the affirming name Holly and to use pronouns she, her. Holly lets you know that she's been telling her parents and anyone that asks that she's a girl. And Stacey tells you that Holly has always picked feminine clothing, and that as a family, they're happy to let her express how she feels as a girl. However, some issues did arise when she was at school. So she started to become angry because other people wouldn't listen that she was a girl, and she started to act out because of this. There was also some issues around toileting, where Holly began holding on most of the day. So Stacey, mum, she's worked quite well with the vice principal at school. The vice principal had a caring approach to support Holly to transition socially with her classmates. So I'd now like to invite Merrin Wake, our child and health practitioner from Queerspace, and Jo Centra, our paediatrician, to speak further to the issues identified by Holly and her family. So thank you.
Thanks, Lucy. Welcome, everyone. So this is quite a presentation that I see quite often in my work, and I guess some of the main points that we look at is we often use language at Queerspace where we talk about someone inviting us in to their identity, and it often has a big impact when you're talking to parents, carers around what that feels like. Often coming out can feel very fearful and scary, and you know that it disconnects the family. So inviting in can be a really great term to talk to about the family and the young person as well. Also talk a lot about language, because language can be quite new to somebody. I think we've gone on to the next slide. Yeah, right. Back one. Oh, okay. Thanks, Lizzie. Talk a little bit too about language and how this language can be quite changeable for young people, and they're kind of questioning about where they fit, what language feels good to them, what feels okay for them to use, whether that's at school, at home, or whatever spaces they find themselves in. I also talk quite a bit about kind of the whole family process and what that fear-based kind of disconnection that can occur with families. And often I hear from families that it may be something new, it may be new knowledge, new language to families, but it's often something the young person has thought about for a very long time. And in this case, particularly, thinking about that Holly's, thought about this for quite a while. So when they actually invite you in, that can be the start of a journey for parents and carers, but it can often be, have been quite a long journey for young people. Lots of the parent carer support can be really, really helpful. I think Lucy said at the start that I'm also the parent of a trans child, and I know for us it was really, really valuable to connect with other parents and carers to talk about, the journey to come up and, vent and talk about what we needed and what was hard and difficult. One of the really important places, as with any young person, is often school, and it's where they spend, majority of their time. And there's lots of resources around gender affirmation plans. I think one of the really important things around this is to think about doing that gender affirmation plan alongside the young person. And that might not necessarily being having the young person sit in with teachers and families, but it might be them contributing in different ways. And lots of young people I know will draw pictures, be creative about showing who their identity is and what they actually need at the school setting. The issue in this case around Holly having issues around toileting and holding all day can make really significant difference around how a then young person engages in education, how they sit in the classroom, how they feel, how they learn as well. And what can be really important is around referrals. So not just to, mental health facilities and healthcare providers, professional people, but also thinking about social supports, about connection to community, about maybe meeting other people that they feel use the same language, have similar identities, or they feel like they belong and connect to. They can be really important parts of this kind of affirming who their gender is. One of the things I talk to parents a lot about and carers a lot about is that this can be changeable at a very young age, that they may use a certain pronoun, a name, and that may change as well. And so it's to be really fluid and think about what that feels like as a parent and carer, and the importance of having a space where the parent and carer can talk about their own experience of this, maybe not with the young person at times, but often making sure that we, every time we have a conversation, that we're led by that kind of affirmative lens, and we talk to parents, carers, schools, whoever we're talking to, about what that looks like for that young person and how it makes them feel. Thanks.
Thanks, Merrin. Sorry, I'm just having issues with my video. That's really fantastic, and that we're able to know that we need to be able to support parents and carers in this way. What I might do is we might move on to Joe, but I've got a couple of questions for you, I guess, around the local services as well. So Joe, I'll pop your slide through. There we go.
Thanks, Lucy, and thanks, Merrin. So I take the opportunity, if I see a young person like Holly, to do a fairly thorough evaluation of the young person and their family and their circumstances in their school and their broader community. So I would be looking at a developmental, psychosocial and medical history for the child or the young person, and seeing whether there's any coexisting issues. So, whether there's any developmental, mental illness or medical issues that we need to address alongside their gender or gender dysphoria, if that's present. I really want to explore with the child, so with Holly, how they want to express their gender, what their affirmed name is and their pronouns, and whether they've had any barriers to living in their affirmed gender expression. I think it's really important to explore the family support, understanding dynamics and functioning, and who important people are for that young person, so who they feel safe with and who they feel that they can be themselves with. So, and often that will be variable between different members of the family. I think it's really important to explore what the young person's experience of school is, because that's generally where they spend most of their time and where they will want to express themselves or might feel challenged in expressing themselves fully. So I want to know how they feel at school, what uniform they wear, which toilets they use, whether they use their affirmed name, who uses their affirmed name and pronouns, and their peers and friendships. I also want to provide some education to the child and the family about gender identity, what gender dysphoria is, and then ways to support gender expression and affirmation for the child or the young person. And also education, which I think Merrin will speak more to, but about relevant groups and organisations to support the child and their parents, maybe their siblings, school, sporting clubs and other areas that they're involved in. I think advocacy is really important as someone involved in healthcare of trans and non-binary young people. And so advocacy for Holly and her family to the school and the community as required, and suggest engagement with things like safe schools, maybe staff advocacy, safe places at school, and the importance of validating the young person's affirmed gender. In terms of referrals, I considered earlier referral to the Royal Children's Hospital's Gender Service, and that's just for assessment before pubertal onset. I'll talk further to the importance of that shortly. I think also it's important to consider a referral to an experienced mental health professional with experience supporting gender diverse young people and children if there's significant distress or dysphoria. And while you've referred the child on, it's really important to continue to support them and monitor their progress. Lucy spoke earlier about this, but I really think it's important to stress it. So in terms of supporting our children and young people who are trans and gender diverse, we think that withholding gender affirming treatment, so that's affirming a child's gender, is not considered a neutral option. So withholding is not a neutral option and may actually exacerbate distress in a lot of ways, including increasing depression, anxiety, suicidality, social withdrawal, and possibly increasing the chances of young people illegally accessing medications. I think Lucy's slide earlier on was great, showing the degree of distress that young people who are trans or non-binary can experience. It's not the experience of being trans that causes these mental illnesses. It's the experience of being trans in our community that can trigger these sorts of really distressing outcomes for our young people in our community. Thanks, Lucy. So I'll just speak very briefly about medical affirmation. And the first thing I wanted to talk about was that all children are individuals, and what might be suitable and appropriate for one child or one family will not be suitable for someone else, obviously. So there's not one pathway. Everyone has their own beliefs and thoughts and needs in this space. Consider an early referral to the Children's Gender Service and psychology as appropriate. There's a long wait list for the Gender Service, as I'm sure you are aware, and it's important to start that process soon. So after a period of medical and psychological consultation, when the young person is seen at the Children's Hospital nearing puberty, they may consider initiating puberty blocking medications. They might be called blockers, and they are gonadotropin releasing hormone analogues, and you can get them intramuscularly and subcutaneously. And currently they are only prescribed in Victoria through the Children's Hospital's Gender Service. I believe there might be some private endocrinologists that do it, but generally it's through the Gender Service. So puberty blocking medication, it relieves the distress for a trans adolescent who's approaching puberty because it pauses pubertal changes, and it's reversible. So a young person will get taller, they'll gain weight, but they'll still have time to develop emotionally and cognitively before they make decisions on whether they'd like to start gender-affirming hormones, so that's testosterone or estrogen forms, that can cause some irreversible changes. So puberty blockers are most effective at preventing development of secondary sexual characteristics when you start at Tanner stage 2 for genital development. But the timing of when you start that is a bit of a balance. So in trans girls, so they're young people who are assigned male at birth, they would ideally start puberty blockers at around stage 2-3, which is when there's enough genital growth to optimise future surgical outcomes if they wish to have bottom surgery in the future, but also avoiding some of those irreversible changes of the endogenous testosterone, like voice changes and masculinisation of the face. So it's really a balance between and a really considered ongoing discussion between the child's clinician and their family and the child on what they want to do. So puberty will begin again once the blockers are ceased, if they're not then using affirming hormones. So in mid to late adolescence, a young person might wish to commence gender affirming hormones, and these sex hormones have a number of irreversible changes, which we'll go through later. And this follows really comprehensive assessment by experienced mental health clinicians. So I probably won't speak too much more about that, but there's a bit of an art on when people start puberty blocking medication. And just to note that that's not an essential pathway to then having hormone treatment later in puberty if required. Thanks.
Thanks so much, Jo. I wasn't sure if we had another slide to go, so that's great. So I guess in summary, and I'll keep Jo and Merrin to have a bit of a chat. So in summary, from a GP perspective, we want to do support the family and the child in community and family referrals. And I want to emphasise what Jo said in regards to referral through to the Royal Children's Hospital. So I would practically be wanting to do an early referral. So I'd speak with the family about letting them know that getting them into the system at the Royal Children's, where there's a 2-year wait list now, that these young people, we put them on the referral pathway for an assessment or an intake appointment, so that that child then has the opportunity to either access puberty blocking hormones or later on needing gender affirming hormones. But it means that they actually have the option, rather than coming in a couple of years' time and they've decided now that they want the referral, it's better to decline it later, I think, if anything changed. And so that's something that I'd really encourage everyone to do. It's a really easy referral document to fill out. The Royal Children's have it's a 1-page document, and they do ask you to include a mental health referral or a comment around whether you have done a mental health plan for the young person. So it's not a barrier to them accepting the referral, but they like to know that the child has been linked in with someone locally for support to obviously prevent or decrease the associated distress that comes with for these young people. Merrin, I have put up on the screen there a couple of the local services. I just would you mind just taking 20-30 seconds just to highlight these for us for family and community referrals?
Yeah, absolutely, Lucy. So we do a program at Queerspace called The Village, which is a 7-week program just for the parents and carers, not for the young person. And this is where we take families through kind of gender and sexuality 101. We talk about the medical model. We have RCH come and talk a little bit about that intake, as you said, that intake assessment. And it's a really helpful, I guess, lens for parents and carers just to learn a little bit more and understand and get that information. And we know that young people tell us, I wish my parents knew more. I wish they understood my language. I wish they could talk like I do. So this can be a really helpful course to take people through, which is at the moment is online since the pandemic. So it's reasonably accessible depending on where people live. And then we have Transgender Australia and Parents of Gender Diverse Children, which are both kind of peer-led organisations that support young people and their families, but predominantly we talk to parents and carers about, you know, what it is to experience this, what they're feeling, and it's a really kind of safe enough space for parents to come to talk about the challenges, the barriers, the joys, the amazing thing about having trans children, which it absolutely is an amazing gift. So these can be really helpful for families not to feel so alone, particularly I would say for regional and rural families who live quite isolated, who live rurally, or who might be part of culturally diverse or other communities where they don't have the language, or they might not, you know, understand what that process might be. So this, in support of medical referrals, RCH and the like, can be really, really supportive in then supporting that young person to kind of affirm who they are.
Absolutely. And I think it's really important to acknowledge that young people and older trans people don't necessarily choose medical affirmation, and social, what we call social affirmation, and the way they live their life can be quite enough for them. So we have to be able to provide them with the resources and the people that can help them along that journey.
Yeah.
So,
and one thing I would say, Lucy, about these organisations too is that there's no barrier, you know, to a child being binary, kind of trans, or going down medical model. These organisations are really open to gender questioning, non-binary, any kind of identity where parents and families and young people want support.
Amazing. Yeah, thank you very much. All right, so we'll move on to our next case, which is an adult case. So I'd like to introduce you to Jesse. So Jesse is 25 years old, and he's here to find out how to go about starting gender-affirming hormones. So Jesse is what we call AMAB. So there's the AMAB, which is assumed male at birth. But now is presenting in a non-binary, now presenting in a binary female identity. So I'd like to ask Nick Brayshaw. Nick, what are your priorities for Jesse, and what approach do you take? Can you, as a GP, do everything for Jesse, or, you know, do you have to refer him on? Thanks.
Well, Lucy, for adults, I think this is not really so different to other areas of medicine, where our job as GPs is really to support people and help them in making their own informed choices. So I think for the majority of patients over 18, affirmative medical care can be provided via an informed consent model, primarily by their GP, with other clinicians involved in the team on a sort of as-needs basis. So given the likelihood that Jesse has previously had unsatisfactory experiences in healthcare, as Lucy alluded to just now, you might like to begin with a statement like, I'm really glad that you got in touch. I'll be pleased to work together with you towards accessing gender-affirming hormones and to figure out exactly which options might suit you best. There is a lot to talk through, so we'll need to do this over several sessions. How does that sound? And then if I can go on to the next slide. So in terms of priorities, first of all, I'd really like to understand what you already know about hormones, what goals are most important to you, and any concerns or questions that you have at this point in time around hormones. Also, at the first visit, I think we need to go back one slide.
Yeah, sorry, Nick, I'm just trying to.
Also at the first visit, I think it's imperative to assess Jesse's safety. Lucy highlighted earlier the level of risk that trans people often face. I find that this sort of risk assessment often fits most comfortably within a sort of broader heads style conversation. And that would also include the other dot points here, certainly a social history and understanding what supports the Jessie has, the attitudes of her family, her social networks, and her interests and vocational connections, and a mental health assessment, and offering referrals as desired or as appropriate for counselling or a psychologist or psychological support, and importantly for peer support, which is particularly for people who are not connected with community or with other gender diverse people is really crucial. The confirming a history of gender incongruence is rarely in doubt. The next slide, please. So Jessie's history is that she never really fitted masculine stereotypes, and in retrospect, this dates back to childhood, even to kindergarten. But she's only recently come to fully acknowledge that. She has a few friends with of diverse gender identities, and recently she's been experimenting wearing makeup and jewellery and feminine clothing in selected safe company. And she says that feels really good and feels really right for her. Next slide. Jessie's mental health, she has a long history of depression and anxiety, past problematic use of substances. She feels she never fitted in at school, and puberty was a really troubled time. She made a suicide attempt at the age of 17 and had subsequent brief engagement with mental health services at that time. But she does have a long-standing connection with a community psychologist, which is important and something which we can perhaps leverage as we work together. Importantly, she's not recently experienced any ideation of self-harm, but she states that she's now come to realise that many of these issues in the past have stemmed from attempting to suppress the true gender identity. Jessie's parents separated when she was aged 7. Mum is trying to adjust to her affirmed name and she, her pronouns. Jessie has little contact with Dad, who's interstate, and she describes as homophobic, so she hasn't broached this topic with him. She has a supportive partner, Taylor, who is cis female, so cis meaning the opposite of transgender, so assumed female at birth and a female gender identity. She's studying at university and works part-time. She's not yet come out, other than just to selected friends and close friends and family. And Jessie states her sexuality as bisexual or pansexual. So a little bit more about the informed consent approach to prescribing gender-affirming hormones, which will be conducted over 2 or 3 or maybe more appointments quite often. It involves taking simply a comprehensive medical and family history, any issues which might weigh on or influence medical recommendations or the way in which things are prescribed. It's importantly about providing information to ensure that Jessie has a comprehensive understanding, enabling her to make an informed decision. Discussing the expected changes from hormone use and timelines for that and what's realistic. Discussing potential complications and side effects of hormones. A basic physical examination, blood pressure, cardiovascular, liver, maybe BMI if she consents, but being mindful of sensitivity many people have around body image and a high prevalence of eating disorders in this group. Do some baseline bloods, baseline hormone levels and basic bloods. Offer a referral for sperm cryopreservation prior to commencement of feminising hormones. And we'll touch on that a little bit more detail later in the talk. And having completed the above, then really finally confirming, assessing, documenting Jessie's capacity to make her own informed decision and provide informed consent to commence on hormones. Next slide. So just running through some of those points. Jessie's past medical history is of mental health we've already covered. She ceased fluoxetine 3 years ago and she's not on any other medications currently. She's a smoker, 10 cigarettes a day, but there's no other significant past medical history or family medical history. Next slide. It's also opportune to set in mind to some additional considerations. I guess in general practice, we're very familiar with opportunistic health promotion, looking at smoking, nutrition, alcohol, physical activity, sleep, and stress management. This certainly may be an opportunity for some motivational interview in regards to assessing Jessie's readiness for reconsidering her smoking. Important to assess her immunisation status, important to discuss sexual health and to flag availability of PrEP, for example, and to discuss future cancer screening implications. Next slide. This sort of informed consent model is suitable for the majority of patients, but not all, and some do require referrals, and many may undertake informed consent model, but it's useful to have other clinicians involved as well. I think social and community referrals, which we mentioned earlier, are really important consideration, helping people to connect with community. There's a number of local organisations, Wellways, Out Social Groups, and GASP in Geelong for people up to the age of 25. Queerspace, which Merrin has mentioned in relation to younger people, but have programs and services and resources for adults. And peer navigation, so peer navigators, people with lived experience who are state funded to provide assistance to people navigating transition or contemplating transition, and they're based in Ballarat or in Melbourne. Mental health referral is required. I mentioned often really helpful to have a psychologist involved if the person is open to that, which most people are. Psychiatry, if there's significant mental health issues or questions, then sometimes helpful to involve a psychiatrist. Gender affirming voice training, really important for many people. And I wanted to flag that Barwon Health just last year have commenced a gender affirming voice service. And so we've got I think in the resources tonight will be details of how to help people access that. If there's concerns around medical complexity, then referral to an endocrinologist can be really helpful to assist with initiating. Next slide.
Yeah, I think that might be the summary slide. I guess I just wanted to ask one question, Nick, sort of in regards to the referral to a psychologist or a psychiatrist. So in my practice and the experience that I have, often there are some people that may not want to see a psychologist. You know, they're feeling they're not necessarily experiencing gender dysphoria as such. And others will want that more from a supportive place to help with sort of family transition or any stress that might evolve from going through their or starting their affirmative hormones, and how that then they interact with their family and the social constructs that they then come across. So yeah, it's not always that they have to go and have a diagnosis. We're trying to depathologize the gender identity, but maybe if you've got questions around the person's capacity to consent, so whether there's a condition that you may find it difficult, that do they actually understand everything that I'm telling them? Is that where you would then potentially refer either to a psychologist or a psychiatrist for some extra support around that as well?
Yeah, certainly, Lucy. That's two typical situations, and I think if there's questions about a person's capacity, then I would definitely seek specialist input or further assessment around that. And for many people, it would be wonderful if people were supported by family, by their friends, in their workplace. And in that instance, many people may not really have much purpose in seeing a psychologist, but unfortunately, the real world's not like that very often. And so for many people, it's helpful to have a psychologist to help them navigate some of those tricky relationships.
Yeah. Thanks, Nick. That was a really great presentation around the adult case that we may face. And I just want to put an opportunity or let everyone know that the PHN do run a trans and gender diverse community of practice that I think everyone, including myself on this panel tonight, all participate in. It's once a month, so I'll give it a plug towards the end as well. But you're all welcome to come each month, because we talk about this a lot, and the evolving nature that the transgender health is just rapidly evolving, so we're growing with it. So that sort of brings us on to our third case, which is Sam. So Sam's a 12-year-old trans male who presents with his mum, and mum is concerned about Sam's mood. So the history from mum is that Sam, in the last 4 months, she's noticed that Sam's become withdrawn from most things, and that Sam is refusing to play netball this season, which she's always loved and excelled in. Mum is also worried about Sam's mental health because she's noticed some cuts on her arms, and how can I help? How do I help? You then go on to take a history from Sam. So Sam identifies as male. He has told a few friends, and they're supportive and respect his pronoun choice. And Sam's happy with being called Sam. He started to feel his mood change when his period started, and he was worried about the change rooms at netball in particular. I don't want people to see me, he said. I hate wearing a crop top, and I hate that I'm getting boobs. So this is a really common presentation, and so I'd like to just now hand over to the panel to speak about the roles in which the GP and other professionals play to support Sam. Thanks, Nick.
Yeah, thanks, Lucy. Well, I'll start off firstly. I think GPs have a really important role to play in providing ongoing support. Whilst young people are often on long waiting lists for other external services, so GPs providing that sort of continuity of care, maybe advocacy, maybe reassurance along the way, and helping to link people to peer support networks, family support, and to community. I think the HEADS assessment is a really important, bearing in mind the high rates of coexisting mental health challenges, which you've alluded to earlier, high rates of neurodiversity, especially ASD spectrum, disordered eating, self-harm, or self-soothing with substances. I think that in all contexts, HEADS really should routinely include an invitation for people, no matter where we're conducting that or who we're with, an invitation to discuss sexual health, sexual attraction, and gender identity. Mental health risk assessment we've alluded to earlier, and that's something which I think GPs are familiar with, but it's really important in this context, given the high incidence of risk factors. So I'll pass on, I think, to discuss social affirmation. Of course, GPs have a role in this, importantly, but I'm going to pass over to Merrin, who's expert in this field, to talk to social affirmation.
Thanks, Nick. Yeah, I think there's a few certain points, particularly at the age of we're looking at 12 and young people starting to grow their independence, become, you know, their identity and their peers become really important at this point. And I guess having safe enough spaces to do that is really important. So not just in the home, but also safety at school. So advocating and supporting young people and their families. It could be as much as letters to school. It could be supporting a gender affirmation plan, as well as kind of the medical model of things that will support their and affirm their gender identity. Things like, you know, we know the outcomes of young people if they have, you know, affirming spaces to be in, and that includes whether it's a sporting club, whether it's a school or home. One thing that we talk a lot about is, particularly for trans males, is around the role of binding, particularly if young people have gone through their non-affirmed puberty. And one of the issues, I mean, I run a binder library, and the impact it has on young people to actually show up in these spaces can be really significant. So, and binding can be done in lots of different ways, and there's lots of great resources on Trans Hub and other places around how that can be done safely and how to access these things. I wanted to also say that, you know, it's really important for these young people that gender, if they do have dysphoria around their gender, and as someone said earlier, not everyone does experience gender dysphoria, but if they do, it can have significant impacts on things like self-care, showering, clothing, different things like that. So it's really important to discuss some of these things, to think about how to support people to turn up to these spaces. So literally to get out the door, to go to school, to keep playing the sport they love, to keep interacting with their friends and different things like that. So I think these, you know, sometimes what we term as practical supports, it's really understanding the impact that some of these practical supports can have. And particularly I know binding and the role of binding in this can have a really significant impact on the young people I support, even just getting up and leaving the house, you know, even just getting up and doing sport or anything like that. So they're really, really important parts of the model to look at how we affirm gender in not just young people, but all people.
So important. Thank you, Merrin. What we'll move on to now, Joe, I'll just ask you to speak about the medical affirmation that GPs also can undertake, but I'll let you talk about this in detail. Thanks.
Yeah, great. Thanks, Lucy. So I'll just talk briefly about menstrual suppression. So in this case, Sam's already started menses, so it'll be too late for puberty blockers, but we could consider gender-affirming hormones if Sam wished. In terms of menstrual suppression, menses can be really distressing for trans males or gender diverse young people who are assigned female at birth, and suppressing menstruation can really help to reduce this distress. So the main first go-to, I think, would be Primolet or northisterone. So we can start at 5 milligrams twice a day orally, and this is probably the best option in primary care, and it's certainly what's recommended through the Royal Children's Hospital for young people who would like to suppress menses. And I think it's really safe to reassure young people that at this point of puberty, this medication is as effective as a hormone blocker to stop their periods. You can start at any time in the cycle, but it's best started immediately after they've had a period. And if that dose, so 5 milligrams BD, doesn't stop their period, then we can increase that. There's a couple of doses you can go up, and then potentially you can come back down to 5 milligrams BD to continue to suppress. It's important to get an authority, so you get enough medication to last them at least a month. rather than needing a script every 1 to 2 weeks. It's really important, as part of your head screen to ask about sexual activity and to remind the young person that just because their periods have stopped doesn't mean that there's not a risk of becoming pregnant. So it's not a contraceptive, and they do need to use alternative contraception if required. There's a few things to ask about in terms of risk before you prescribe medication, including family or personal history of clotting risk, their mood, although that would not be a contraindication, depression and low mood. It's just something to think about and perhaps prepare the young person for, and the potential for weight gain. And the young person can stay on this for a number of years if they would like to start testosterone, so they could go straight onto testosterone if they wished. An alternative might be the oral contraceptive. So, and they would just take continuously active pills without a sugar pill, and that's a safe way to take the pill in this form. And then beyond that, I'd probably be talking to a gynae just about suppression personally, because I'm not a GP, but I think Mirena and Implanon would be other methods of suppression that you might be comfortable with as a GP. Yeah.
Great, thanks, Jo. Yeah, that's definitely something that is really quite straightforward to implement for your young people when they are distressed around their periods. It's to see the eyes light up of the young person when you say, would you like to stop your periods, is pretty rewarding, and when they can tolerate the medication. So I've only had a few people that potentially have some side effects, and that may be some nausea or some dizziness, but often it's pretty well tolerated, and it can be really, life-changing for that young person just to not have to worry about getting their period and being reminded of the gender that they don't identify as. So it's really lovely. So I do encourage people to look on the health pathways. There's a really straightforward drop-down box within the trans pathways on health pathways that you can follow to be able to initiate this for your patients, and being able to do it yourself without necessarily seeking any specialist care. So I would like to just let you know we're going to fast forward a little bit to meet Sam as he gets as Sam gets older. And then beyond, after we've had a discussion at Sam when he's 16, we'll then have the option for Q&A. So please don't hesitate to be putting some questions into the Q&A or into the chat. Because we'll have plenty of time for questions, or even if at the time that's when you decide to ask, pop them in. All right, so as I alluded to, Sam's now 16. He's returned with his mum and dad, and they're requesting support for gender affirming hormones. So it must be acknowledged that that Nick has already alluded to as well, there's long wait lists to see the specialist service for the Royal Children's Hospital. And in fact, because of that long wait list, the Royal Children's have closed their books to anyone over the age of 16, just so that they can service the younger population, because there is a thought that the 16 to 18-year-olds can there is a service through Monash Gender Clinic. They're accepting referrals over 16, but hopefully we as GPs can be able to support these young people and provide. So I'm going to talk to you about sort of the difficulties that we are experiencing as GPs at the moment, but hopefully let you know about the evolving space that it is. So the referral pathways for young people, 16 to 18-year-olds, to access gender affirming hormones, they're, as I said, rapidly emerging. And the Royal Children's standard of care is that the optimal model of care for trans and gender diverse young adolescents who present to services, it should be a multidisciplinary team approach. So Within the Royal Children's Guidelines, actually acknowledge that general practitioners are placed very well within the community to coordinate a multidisciplinary approach with specialist practitioners and community-based clinicians. And this is an effective alternative to them necessarily being through one of the gender services. So this multidisciplinary team is generally made up, obviously, of the general practitioner, a mental health clinician, a paediatrician, and a fertility specialist or counselling if the other sort of general practitioner or paediatrician feels that that may need to be required. So access, in reality, it is difficult, but is evolving. And I want to encourage people to contact the Royal Children's Hospital Gender Service phone advice line. So this is a GP only phone line that allows, and I'm just going to pop the number up now. So it's accessible Monday to Friday. It goes through to the resident who's working in the gender clinic, and your questions are documented and referred to the appropriate specialist, whether that be the paediatrician or the psychiatrist or mental health clinician, and they will endeavour to help support you either find someone within your community that can help form that multidisciplinary team, or provide you advice to support your young person. I also wanted to let you know that the Geelong region is working towards better pathways for this age group to access because we know that access to paediatricians and mental health clinicians is very difficult at the moment, and there's just such a strain on these specialties. And so we as GPs and the Royal Children's are advocating that hopefully we can try and change that for particularly in the Geelong region, but also in the regional and more remote parts of Victoria, that the Royal Children's are going to be supporting where possible GPs in helping these young people. So when you feel you've had this multidisciplinary approach, and that's been the basis of your care for your young person, so ideally that there's a mental health clinician working with you, that for adolescents under the age of 18, the AusPath guidelines do support potentially starting this informed consent model. So the consent becomes a bit more difficult from a legal perspective. And so I'm going to run through that with you now. So we have to ensure that there's no dispute between the parents, the medical practitioner, and the young person themselves. And it also includes disputes between parents about potentially starting gender-affirming hormones or treatment. And it's based on 3 things. And so those 3 things are the competence of the adolescent, a diagnosis of gender dysphoria, or a proposed treatment for gender dysphoria. So the first 2 elements there, the competence of the adolescent and the diagnosis of the adolescent, are probably the key elements where the mental health clinician is going to work with your young person and you as the GP to provide, to assess the competence of that young person and ensure that that they're able to make the appropriate decision, and that the parents actually agree with you on that. If there is any dispute between any of these parties about any of those elements, there is legal precedent that it must be referred to the family court through a mandatory application. And this was this is the basis of the case from 2020 called Re-Imaging. So I'll just summarise that again. We want you to be able to work with a mental health clinician and yourself as the GP to support that young person and establish the competence and diagnosis and talk to the family about the potential treatments. And if and there also at this point needs to be involvement of a paediatrician, and that may be through talking with the Royal Children's Hospital as well. And then we can think about supporting these young people. And as I said, we're working really hard within our local communities to make this pathway a lot smoother, and I think it's going to evolve very, very quickly. So also a huge part of the informed consent is talking to young people and their family about fertility. So I'm going to ask Nick to sort of elaborate on that a little bit more. And please don't hesitate to ask any questions because it is a grey area. Happy to explain it again. Just let us know. Thanks. So Nick, I'll hand over to you now.
Thanks, Lucy. It's a complex situation. I think you've explained it really well. In regards to fertility, it's a really important discussion to talk about the implications for fertility for people of any age prior to commencing gender-affirming hormones. Both feminising and masculinising hormones do substantially reduce fertility, but neither of them can be relied on for contraception. Sperm storage should be offered to everyone before commencing estrogen. And similarly, before starting testosterone, transmasculine people should consider the availability of oocyte harvesting and storage. It used to be said that infertility was a permanent effect of gender-affirming hormones, up until in recent years, really. But it's now becoming clear that ovulation is usually restored quite quickly if testosterone levels lapse. And in part, hence the need for contraception, for concomitant contraception. More recently, evidence that many people do in fact also restore spermatogenesis if they cease feminising hormones. I guess that one big issue though for many people is that it would be a very big undertaking and potentially quite problematic to cease gender affirmation in order to achieve a pregnancy. And hence it's really important to discuss this and for people to consider their options before commencing on hormones. And sperm storage is easily arranged. I won't go into any more detail tonight because in fact, Dr. Prue Johnston from Monash IVF will be talking in more detail on this very topic on the 5th of April to the Trans and Gender Diverse Community of Practice, which anybody attending tonight is very welcome to contact Ingrid Dwyer at the Primary Health Network and can register to join that meeting. So that's just a brief overview of fertility. I'll leave it at that for tonight. Just talk a little bit more though about hormones themselves without time to go into great detail. But it's important to acknowledge that everybody's goals, everybody's expectations, everybody's situation is different. And so, as in so many areas of medicine, it's really important to individualise to suit a particular individual's needs and priorities. And that's part of the process that will be established during those discussions towards informed consent. And that will guide the dose and the form of testosterone required for this particular patient. In general, we'd start on the low dose, monitor blood levels, and importantly, monitor patient experience to guide titration of dosing. Testosterone is available to be prescribed freely by general practitioners as private prescription. In order to access PBS, where it's available on authority, requires involvement of a specialist, either endocrinologist, urologist, sexual health physician. But that's if the person wishes to access PBS subsidisation, that can be arranged, and there are endocrinologists in Geelong who are now really experienced working with trans men. So testosterone comes in a number of different preparations, different forms, essentially injections or transdermal preparations. Most commonly used probably is the first top one there, Reandron, which is an injection roughly every 3 months. I won't go through all of the other in detail tonight. In regards to feminising hormones, similarly, this is important to individualise according to persons' expectations and goals as established during the informed consent discussion. And that will guide the dosage and form of oestrogen and with or without an anti-androgen. Most often, an anti-androgen is prescribed in conjunction with oestrogen. Oestrogen alone suppresses testosterone to a degree, but not to the levels that we would often seek. And so, depending on an individual's goals and preferences, again, we'd very often include an anti-androgen as well. Progesterone is not generally prescribed. There's very limited or no evidence of efficacy in regards to gender affirmation in terms of the scientific literature. But it is very popular anecdotally amongst community and on many of the social chat groups and so forth. So patients often do request it. So it's a discussion and I guess taken on an individual basis. In regards to the preparations of estrogen, there's a number of different formats. We generally lean probably more towards transdermal preparations than oral, particularly for people of sort of middle age onwards, because of the safety profile. But transdermal gels or patches are widely used. It can also, there are available subcutaneous estradiol implants from compounding pharmacies, which, although not TGA approved, have become quite an established option and certainly very convenient for people because they generally last 6 to 12 months, sometimes more. In terms of anti-androgens and progesterones, essentially the two anti-androgens that we use are either spironolactone or cyproterone. And if prescribing progesterone, we generally lean towards micronized prometrium because of its better profile. Next slide. Yeah, okay.
Yeah, thanks, Nick. I just wanted to point out that those particular screenshots that were up with the formulations are all from the OzPath informed consent guidelines, so easily accessible online. But again, we'll provide you with some resource links to that. And now I'd just like to invite Merrin in regards to just talking about Sam, 16-year-old Sam, and what what comments do you have around supporting Sam at this stage? Thanks, Merrin.
Thanks, Lucy. I guess I just wanted to first reiterate what I think Joe and Nick and Lucy have all said, is that this is a really key time of adolescence, and we know, by not doing anything or not offering affirmative care can really have significant impacts on young people, particularly of that kind of age between 14 and 17. Really important things around this age is that they're becoming independent in their healthcare. They want to access healthcare. So supporting them around Medicare changes, around documentation changes. We have birth certificate reform in Victoria, where people are able to change their gender marker as well as their name on their birth certificate with parental consent. Again, goes back to Lucy's discussion around some legalities around if there is differing opinions or differing ideals of what that looks like. But this can be a really important part for things that I guess assists often young people maybe take for granted, things like getting their license, getting employment, even getting a bank card. Being able to ascertain these things really gives their independence in then accessing what they want and accessing their hopes and dreams for the future. This age group as well, even 12 and 16, is that social affirmation really remains key to this. So whether they're in the workplace, whether they're in a school setting, is ensuring that, forms and things are changed. And there's lots of resources from Safe Schools and a few other places where schools can be supported to do this. They can change names on Compass cases, different kind of processes. And I guess thinking about, these young people who might turn up and maybe misgendered 1 or 2 times a day, or even 50 or 60 times a day, that again can have a really significant impact on how these young people show up to even your service as a GP or navigating any spaces that they're in. Confidentiality and privacy is really important for these young people, again, gaining their independence and understanding who they are and where their identity fits in the world is a really great discussion to have very early on with the young people. Obviously, doing risk assessments and understanding competency and things in young people is important. There's also that importance about how we do this. And I think we know the outcomes for young people if they have spaces that they can be affirmed in. And that can be as easy as, inviting parents and carers into having more knowledge, and whether that's the village program, whether that's sessions, even with the GPs, with the consent of the young person, is understanding that. One of the conversations I have quite often at this age, around 16, is around where is it safe enough for these young people to be themselves? Where do they want to use their names and pronouns? What fits with them? And it's really important to be guided by that young person, not make assumptions that just because you use an affirming name and pronoun that it's safe enough for these young people to do that at work or do that at school or do that at home. So it's really about that listening to how this impacts and where that social affirmation they would like to take place, because it may not be safe enough in some spaces for young people to do that. And the only other thing I guess that I would talk about here around is the advocacy that a GP can offer. Again, whether that's writing letters to support Medicare changes, whether that's writing letters to schools to support that advocacy around them being supported by medical professionals, no matter what their transition looks like, but that these other spaces, I guess, have the backup or evidence or knowledge from a multidisciplinary team around this young person to be able to acknowledge that this is important to them and this is the processes that we need to go through. So I can't stress enough, I guess, around how social affirmation really remains the key to this. As Lucy alluded to earlier, there are long wait lists. It can be really hard to get assessments done. So that social affirmation can be things that we do and support people to connect with community and have in their own life to be able to affirm who they are, to turn up to spaces that, support them in their well-being. Thanks, Lucy.
Thanks, Merrin. You so eloquently said that. I could not say that any better. What I wanted to elaborate on, you mentioned the safety of using pronouns, and what I'd really encourage general practitioners to do is just have a reflection on your workplace where you are. Have your staff had some training around inclusivity? There are places that you can access free training for your and some formal paid training for your staff to be provided education around this. So that, you know, maybe that young person wants you to use their pronouns, or adult wants you to use their particular pronouns, but when they're at reception, they actually use different pronouns. And so that's really important to establish and just ask the person that you're seeing what they want. It's about the communication is key. Also just have a reflection on the type of software you're using as well, making sure that that is inclusive, or if someone's old name comes up on their form, just letting them know that their pathology form may have their what they call their dead name on there, and this is why, unfortunately, it may be still like that way with Medicare, and so being able to advocate for them to be able to potentially change their name so that then they're not being re-traumatized each time they receive a pathology form, things like that. So just to sort of summarize in regards to the referral pathway for an adolescent. So always having the Royal Children's and the AusPath guidelines sort of in the back of your mind, but I'll say it again, the social and community family referrals are so important. To consider, definitely provide a mental health referral for your young person, particularly, you know, 16 to 18-year-olds. We need the mental health assessment around capacity to consent as well. Referring to a paediatrician. There are some endocrinologists, particularly in Melbourne, not so much in Geelong at this stage, or that I'm aware of in other communities, but that will see 16 to 18-year-olds. So keep your ear to the ground about who those people are. Thinking about the fertility side of things, and again, referring for allied health. So speech pathology if voice is particularly dysphoric for your young person. If there's any concern around eating, emerging or eating disorders, you know, a dietitian, or if there's any other weight concerns that may be contraindicated when the young person starts gender affirming hormones, that maybe they need to see an exercise physiologist. So there's a whole umbrella that we absolutely need to open for that young person, so that they that we can provide them the care that they need. So I'm just going to check the Q&A chat because we've got opportunity for that now, and just see. So I've got a question from Simon, and he's asked, does Barwon Health speech pathology see adolescents or just adults? Good question. So at this point, just seeing adults. There is a very interested speech pathologist who works at the Ballerine Healthcare. She's currently on maternity leave, but I think once she returns, we'll be hoping to aim for providing speech services for adolescents. Merrin or Nick, I'm not sure if you've heard any further on those sorts of things, but it's a watch this space. So Barwon Health for adults, but yes, there will be into the future, hopefully soon, something for young people as well. And Karina has asked, can I ask for advice on how to offer cervical screening to a trans man? Great question. So maybe I'm happy to answer it, but Nick, maybe you want to field that question. How would you?
Sure. Look, I think certainly cervical screening is really important for trans men, as anybody who has a cervix and has been sexually active. It's obviously often a sensitive issue to raise, and sometimes can be dysphoria provoking. So it's a conversation, obviously, to, as I'm sure you'd realise, to navigate with that in mind. But nonetheless, a really important topic to raise. Essentially, I guess collecting a sample is really the same as for somebody who's cis female. There is often can be atrophic changes related to testosterone use, and so there's often worth considering using some topical vaginal estrogen for a few weeks prior to collecting the sample, both for patient experience and comfort, and also hopefully for a more suitable, not risking an unsuitable sample. There is, of course, now also the option for self-collection of cervical screening samples, and that's an option that may be preferred by many trans men, although some find, I know some find that the thought of doing that is more dysphoria provoking than the thought of having somebody else collect a sample for them. So I guess it's an individual needs basis. Lucy, what would you say?
I tend to agree. So I was answering a question in the chat. So, but I would, just be definitely having a conversation around how the person refers to their genitals, and if they have a particular word to be using that to make them feel more comfortable. A lot of trans people will prefer the anatomical term, but they may have a particular word that they would prefer you to use, and so I would use that in approaching that as well. And revisiting it potentially if there was any concern, revisiting it at another time as well when maybe they feel more comfortable, just saying, hey, would you feel comfortable talking about cervical screening again? And I think it's really fortunate now that we're doing self-collection, that I think that there's probably going to be a lot more uptake. And we've had a couple of other things pop up in the chat. So Julie has let us know that in Ballarat, there is a physician endocrinologist, Dr. Tony Kemp, who's happy to see 16 plus year old patients, which is great news. And so if anyone has any other hot tips, let us know. And we have also a question from Sue, and I might ask either Nick or Joe maybe to field this question. So Sue's asked, it would be great if these young people, especially those without capacity to pay, could somehow access a paediatrician who could be part of the team. But how likely is this locally? So I think you've hit a really relevant point that it is really difficult at the moment, but maybe Nick or Joe might be able to provide us with.
Yeah, thanks for your question, Sue. It is a really difficult space, I'll be honest. Fortunately, in Geelong, we are now lucky to have a lot more public options for general paediatric care. We don't have a public option for gender supportive care within the paediatric space. I see a number of patients privately that I have shared care with Nick, but me, like most paediatricians around, I'm at capacity privately, really. I do try to do as much as I can, but it's difficult. We are kind of in the throes of really trying to develop a broader gender service for the Barwon region. So we've had a number of workshops for that, and a number of people here today have been involved in those workshops. But still, that's a little way off. So I've been in touch with our the paediatrician who's running our general clinics, just to flag that I think that we probably need to consider taking in some of these patients into our general clinics. So leave that with me. We'll keep working on that because I hear you. We really do need far more broader access, particularly for people who can't travel, who can't afford to see a paed in Melbourne. And so, yeah, we are working on that, but I don't have a great answer for you at the moment, I'm afraid.
Yeah.
Thanks, Sue.
Yeah, Sue said thank you. Merrin, did you want to make a comment or?
I just wanted to, I mean, add to Jo, yes, it is really difficult. But what I will say is I hear from lots of families and young people that having a GP that is knowledgeable, that has networks in the community, so they might not be able to directly see a paediatrician, but they have that supportive RCH hotline or whatever that is really, can actually really hold these families and young people in a space to really be affirmed with who they are. And it can really change a lot. Like, it can change how they show up in spaces. So I think don't underestimate that. Yes, there's wait lists and yes, there's work being done, but the role of the GP is can be absolutely gold for families. And, you know, our own GP at the start said, I don't get this, I'm not sure what to do. And nearly 5 years later is, you know, absolutely the biggest support we've got. So yeah, don't underestimate the impact you can have with your gaining more knowledge and skills.
Thank you, Merrin. I think on that note, we might wrap it up, because that is the goal of what we want. We want GPs to be that centre person and just being open and inclusive. Thank you. So I want to thank everyone for Zooming in tonight, and I wanted to thank the panel and the expertise that they've brought to our discussion this evening. You'll be able to access the resources, as I said, via the Trans and Gender Diverse resource on health pathways. We'll try and get some document out to you with some of the resources, including sort of the voice referrals through Barwon Health as well, for example, I should say. And I just wanted to, obviously thank you for all for coming. There is on the next slide, the evaluation survey. So please ask you to complete that. And I think that helps go towards confirming your CPD as well. So thank you all for participating. We've got a few thank yous in the chat. So I just wanted to encourage you, if you do want to come along to our once a month session, it's usually 8 a.m. via Microsoft Teams. So if you contact Ingrid Dwyer through the PHN, she can provide you with a link to participate in our chats. They're generally, we generally have some guest speakers and have opportunity for case discussion, and we talk about everything that's evolving and any issues that people are facing and how we can advocate for our trans and gender diverse community. So thank you all, and we'll see you on.
Lucy, can I just say thank you to you? Lucy's stepped in at short notice in the last 2 or 3 weeks in Bianca's absence and done a huge amount of work in pulling this all together. And I think you've done a fabulous job, Lucy. So thank you.
Yeah, thanks, Nick. No worries. Right, thank you all very much.